long-term complications of acute pancreatitis, may invite the chairpersons, Dr. Vikesh Singh, Professor of Gastroenterology, Johns Hopkins University, USA, Dr. Ilavarasi, Senior Consultant Gastroenterology from Chennai, Dr. Rabindranath Ishwaran, Senior Consultant Gastroenterology, Narvi Hospital, Vellore.
Good afternoon, everyone. So, for the first talk, I invite Dr. Sudipta, Professor Gastroenterology, CMC Vellore, to deliver the talk on long-term outcomes of venous thrombosis in acute pancreatitis.
Thank you, Lavarsi, and thank you, everybody. So, before I start today's Teachers' Day, and I would like to take this opportunity to thank all the teachers who have guided me and every one of our students in the path that we have taken. So thank you, everyone. We'll be totally indebted and remain forever indebted to all our teachers. Thank you. So my job today is to just take you through the journey from inflammation to fibrosis and talk briefly on the long-term outcomes of venous thrombosis and acute pancreatitis. Now, when we talk of thrombosis, there are two aspects to it. One is hemostasis, the other is thrombosis. Hemostasis comes into picture when there is actually an injury to the wall, the tissue factors get released, and that's when the thrombus forms to prevent. So it's a protective mechanism. Thrombosis, on the other hand, happens in relatively healthy vessels because of sluggish flow, and the vessels get blocked. And this was described amply in 1856 by Virchow when he described the three entities of endothelial injury, hypercoagulability, and stasis. And all of this is required to form a thrombus. But before we go any further, I just want to show you this particular picture. This is a picture of a horseshoe crab. I don't know how many of you know it. It's one of the few, when you say this royal blood, this is the royal-blooded animal. It has blue blood. It's blue because instead of hemoglobin, it has hemocyanin, which is a copper-containing enzyme to carry oxygen. So why this is important, now it's actually being cultured on a factory basis. It's like an industry process that is being used, and that's what you can see on the right lower quadrant. What's important, it has got amebicides, and amebicides produce Limulus amebicide lysate, which is an endotoxin detector. What it does is, moment Limulus amebicide lysate comes in contact with endotoxin, it forms a coagulum. So horseshoe crab is probably the animal which is I would say the benchmark for innate immunity, because the way it protects against bacterial infection is by forming a coagulum when it comes to contact with endotoxin. But human evolution and animal evolution has been such that bacteria started producing streptokinase, which destroys that. So yeah, that's how it is. So inflammation, thrombosis, I think is more of a bidirectional approach where you have inflammatory drivers of thrombosis, and this is further amplified by the inflammation. So in the circulation in acute, you take any acute inflammatory condition, whether it's acute appendicitis, you have a trauma, a gallbladder injury, you can have cholecystitis, you can have portal vein thrombosis. So there is inflammatory drivers of thrombosis like inflammasomes, NETs, pro-inflammatory cytokines in the circulation, and of course there's endothelial dysfunction. And this is further amplified by the circulating thrombin, platelet activation, fibrillation, degradation products, and all of this working in a bidirectional manner, producing a condition which we call as immunothrombosis. But in acute pancreatitis, we have known for long that coagulation disorders exist, and microcirculatory blocks have been described. We've had cases from our center when we described the existence of thrombotic microangiopathy and acute pancreatitis, large vessel involvement. And this is primarily driven by three factors. Of course, endothelial cells, the innate immunity coming to be within play, and of course, coagulopathy. Unfortunately, we still do not have very good data to say about stasis and things, but probably animal data does exist on stasis of flow within the pancreatic circulation. So if you look at the risk of planktonic venous thrombosis, this is a meta-analysis. If you look at the timing, early on, between 0 to 3 days, it's higher. If you look at the severity factors is basically as the severity increases, the risk of planktonic venous thrombosis also keeps on increasing. And when you have necrosis, the risk is slightly higher. Now, if you go back, what actually drives this is a failure of the anticoagulation fibrinolytic pathway and an increase in the inflammatory pathway. And that is driven by stasis, endothelial activation, again, NETs, tissue factor expression, and platelet activation. And we did this study a couple of years, got published last year, of course. But this is where we looked at endothelial activity in acute pancreatitis using VWF and ADAM-TS13. VWF is a protein which is secreted by the Weber pallidary bodies within the endothelial cells. When they get activated, they release the ultra-large von Willebrand factor. Now, to keep the ultra-large von Willebrand factor is a thrombotic agent. It tends to plug onto platelets and forms a large coagulant. To keep it in check, we have in the circulation a metalloproteinase called ADAM-TS13, which keeps on chopping it and keeps it in size. What we realize is, in acute pancreatitis, people have high VWF ADAM-TS ratio. The collagen binding activity is higher. All of this shows that there is an imbalance in this ratio, reflecting a degree of endothelial activation. And it's worse in patients who have persistent organ failure or those who go on to develop necrosis. We looked at it further, and with this another tip called the thromboelastography, and this is Krishna's work, which he is probably presenting in an oral presentation sometime. So here we looked at thromboelastography in acute pancreatitis, and what we did see was that, okay, I'll just go back further before I do CRISPR. This was again experimented by an animal study by Rao, where he looked at thromboelastography in these subsets, and when he looked at, he defined hypercoagulability as high MA and maximum amplitude and high coagulation index. With this, what he noticed in the animals who have between controls and animals, there was significant difference between the maximum amplitude and the coagulation index. Interestingly, it is higher in the beginning of the inflammation. As time went by, it started to come down. So acute pancreatitis is probably hypercoagulable, but it's on the early days of the illness. Krishna did this work, which I was alluding to earlier. We looked at the same parameters and looked at mechanical index. And when we looked at acute pancreatitis, there was significantly higher mechanical maximum amplitude in people who have acute pancreatitis as compared to controls. When you look at a violin plot, you can see that in versus acute pancreatitis versus healthy controls, there's again a significant difference. And what is more interesting, which I wanted to come faster to this, is that if you look at the coagulation index, again, as in the animal study, in the humans too, over a period of time, the coagulation index tends to come down, suggesting that initial days when the inflammation is severe, you see more thrombosis, more risk of thrombosis, more hypercoagulability, but as time goes down, within 5 days, it tends to come down. So, what is the driver of this? One of the possible factor is release of tissue factor from the cells. And if you look at these studies, which looked at between 2006 to 2017, all the studies show that there's a high circulating tissue factor levels in acute pancreatitis. So then we looked at what was splanchnic venous thrombosis. And this is a study which came out this year in pancreas. We had an 11% incidence of pancreatic venous thrombosis. Most of it happened in the retropancreatic splenic vein, and 3 of them did have concurrent DVT too. So if you look at the data, what happened to this, and we had a follow-up data of 6 months, we kept on calling them, did ultrasounds, Doppler studies of these patients. Complete recanalization happened in 54%, partial recanalization in 2.9%, and no recanalization in 42%. But therapeutic anticoagulation was given to 20% of the individuals, but it did not seem to affect the recanalization rates. Amongst the patients who recanalized, 79% did not receive therapeutic anticoagulation, and they are the spontaneous recanalizations. Of course, when they do not recanalize, there is a risk of gastric varices. 3 of them went on to develop pseudoaneurysms, and none, of course, had GI bleed. If you look at the factors which determined the recanalization rate, the only factor that seemed to affect it was the degree of inflammation, possibly because the BICEP score was the determinant of non-recanalization. So what we concluded is probably more severe inflammation, risk of recanalizations is less. At the same time, in pancreology, Vincent Ribos and team also showed their data of splanchnic venous thrombosis, and what they showed was that in their cohort, actually, they had almost an equal distribution between splenic, portal, and mesenteric vein. But again, interestingly, if you look to the graph to the right, therapeutic anticoagulation, which was given, which is the blue line, and the preventive, which is you give for deep vein thrombosis, did not seem to differ. So using therapeutic anticoagulation did not make a difference in the rates of recanalization. So recanalization rates were, however, lower in patients with portal vein thrombosis. And when they followed it up, this was a longer follow-up of 3 years. What they showed was a lot of them went on to develop esophageal varices, gastric varices. GI bleeding was there in a small subset of patients. And when they looked at the predictors of recanalization, splenic vein thrombus does tend to recanalize. However, use of anticoagulation did not make much of a difference. So in 2022, of course, this was from the Dutch pancreatitis study group, which they did SRMA, and they showed that if you look, use of therapeutic anticoagulation did not make any difference in the recanalization rates, in formation of varices, collaterals, or cavernoma, and the risk of hemorrhage or mortality. Therefore, to conclude, what we can conclude is that splenic venous thrombosis is seen in almost 10 to 20% of patients with acute pancreatitis. Retropancreatic splenic vein, probably in India, it's the most commonly affected vein. There is a risk in patients who do not recanalize of developing portal hypertension, but more importantly, as of now, I think the role of anticoagulation is debatable. Thank you for your patient hearing.
Any questions from the floor?
Thank you, Sudipta. That was amazing talk as always. Couple of questions. One, we have noticed that the splenic vein thrombosis spontaneously recanalizes, so we generally do not do anticoagulation. But for portal vein thrombosis and SMV thrombosis, those are the ones we really anticoagulate. But we have also noticed from the Indiana University experience that, are we underdosing these patients when we do the therapeutic anticoagulation? Because, we have a lot of procoagulants and anticoagulants in the pro-inflammatory milieu, and we use the standard Lovinox or standard anticoagulation. But is there a role for a higher dose for anticoagulation?
So, Guru, actually, I don't have an answer to that question, but I agree with you completely when you said that the RPSV or the retropancreatic splenic vein is probably, it opens up on its own. Even the problem is only with the portal vein and splenic vein thrombosis, superior mesenteric vein thrombosis. In our study, we did not have a per protocol approach because every consultant had a different way of giving anticoagulation. Some preferred to give only once a daily, some gave twice daily. But even in that subset of patients who received therapeutic anticoagulation, then a twice a day dose of enoxaparin, it did not seem to have a major effect on the outcome of the thrombus. The other point is also most of the studies, there was not a per protocol CT scan done at every point of time, neither in ours nor in Vincent's study. And I think there's a room for further research in this area to see, as per protocol, we do CT scans at every 6 months, 1 year, cost implications, exposure to radiation prevents us from doing this. So we have not explored that fully, but I think there is a scope for doing some work in this area. Thank you.
Can I ask a question?
Yes, ma'am.
How long do you anticoagulate them? Like supposing we have patients where you see it's going into the SMV portal vein. So is it that after 3 months the status is same, you will stop the anticoagulation, the inflammation has subsided, or is there any recommendation on that?
So ma'am, what I have seen from the data that we had, and again, anticoagulation was not per protocol, it was based on the consultant deciding on anticoagulation. Most of them opted to stop once the collaterals formed.
Okay.
So what I have seen in those subsets which have been stopped, they had once the collaterals opened up, the anticoagulation was stopped. So probably it really didn't make much of a difference in the subset, but that is the stopping point probably.
Okay.
Sir, first of all, it was a nice talk. Recently, many reports on pancreatico-portal venous fistula have been published. One of the proposed pancreatico-portal venous fistula. One of the proposed mechanism is portal venous thrombosis followed by the development of pancreatico-portal venous fistula. In such cases, do you recommend that anticoagulation because there is risk of bleed in PPVF?
I don't know because I have not come across that condition as of yet, but I did see the reports and I really don't know the right answer to that question. So I probably may not be able to answer this, and hypothetically I don't want to give you a confusion statement. Thank you.